ahead and share my screen. Maybe I am. Okay, so you all should be able to see my screen right now. So welcome to Probing the Literature. This is the October installment. Maybe I'll be able to get my computer to move. So our schedule, as usual, we start out with a brief welcome and introduction of our speaker. We do the first article, which is a brief presentation, and then any questions. Then we will get back together. I'm going to ask everybody to mute who's not talking, please. And then we will use the second article and break up into small groups, although we may be slightly larger groups today, and basically discuss the article. We'll come back and we'll kind of do a group summary, wrap up with some closing remarks, and then if anybody's going to stay for the method consult, we'll pull that together, although I cannot stay after 3. So we'll see how this works. So the first article we're going to talk about, this month's theme is cardiac and resuscitation, is the feasibility, utility, and safety of fully incorporating transesophageal echocardiography into emergency medicine practice. And I am so excited today because we actually have Robert Reardon with us. So Rob is going to be taking it away momentarily. He's the Assistant Chief and Ultrasound Director for the Department of Emergency Medicine at Hennepin, and also professor of the University of Minnesota Medical School. And I also happen to know that he's part of WinFocus and also the British Medical Ultrasound Society. So not sure how you work that one in, but I think we'll find out soon. All right, so go ahead and I'm going to stop sharing. And thank you for joining us, Dr. Reardon.
Hi, can you hear me okay?
Yes.
Okay. So I don't have any slides or anything. I'll just, you want me to just present the kind of the basics of the paper, right?
Yeah, just kind of go through the basics, and then particularly any lessons learned at the end of it that you can share with us about the research, the process of doing the research would be great.
Okay, so we started using TE. A few of us in our department started using TE in about 2013. And we thought it was pretty easy to learn, and we thought it was pretty helpful, and especially in cardiac arrest and near cardiac arrest. And what we noticed right away is that you could put the probe in and you didn't have to hold it to get a good image. All you had to do is put it in, hang it up above the bed, and you could see the heart through the whole case. You could leave it in for an hour or 2 if you wanted to, but there was no other manipulating it once you put it in usually. And so because we thought it was so easy to learn, the chief of our department, and especially Dave Plummer, who's one of the first ultrasound people, first emergency physicians to do ultrasound in the country. He published some stuff back in the late 80s and early 90s on echocardiography and the ED. He thought that it would be easy to train all of our faculty. And our chief actually said, hey, we're not just going to train everybody. I'm going to make it mandatory that everyone in our department get credentialed or they can't work here. I initially thought this was kind of a bad idea because I imagine there's all kinds of problems because some of our people don't love ultrasound as much as I do. And I thought it would be a little bit of a mess maybe. But anyway, we went ahead and taught 52 physicians, all of our faculty in our department, and we did it with a 4-hour training session. We bought a mannequin, a CAE mannequin, and we just trained them on the mannequin. And then they had 2 hours of didactic and 2 hours of hands-on training on the mannequin. There was no training on human subjects or other subjects. It was just on the mannequin. Actually, it's more than a mannequin, high-level simulator, I would call it. And then we credentialed them and we let them loose. And then we just tracked them over the next 42 months to see how they used it. When we first went to credential everybody, the cardiology department actually asked if they could supervise our credentialing and our training. I just asked them, you know, have you ever done this in a cardiac arrest? And they said no. So I said, well, then you can't supervise us, because that's what that's our plan, is to mostly use it in cardiac arrest and near cardiac arrest, at least really sick, critically ill patients. So, so over the next 42 months, we kept a database of every TE that was done. And we think we captured all of them, because we actually went over our QPath database, and they were all done in the same room, the room we call the stabilization room, which is where we do all the critical care. We only did it on intubated patients. And if a patient was intubated, they were always in that room. So we have pretty tight control in that room. And so we're pretty sure we caught all of them. If you look at figure 1, this kind of figure 1 shows you who did the ultrasounds over the 42 months. So the black bars are the faculty who are not specifically trained in ultrasound. So these are people who didn't do a fellowship and don't have any special interest in ultrasound. You'll see the person who did the most was one of the faculty who works full-time nights. I work full-time nights, and he always likes to beat me in things. So I think that was his motivation, is that he wanted to do more than me. And he actually got, of course, really good at it, because he did 50 of them, or nearly 50. But you'll see the distribution of the faculty is all over the place. The people who were trained in ultrasound or did a fellowship tended to do a little bit more than the rest. But you know, the average faculty did quite a few, an average of 10. Some of the ones that only did 1 or 2 are faculty that don't work full-time at Hennepin. They might only work a couple shifts a month. But every single faculty of the 52 did at least 1 exam. And then what we did is we took the database, we looked over all the images, and we graded them as, at least the images that they collected, as fair, or good, fair, or poor. Good meaning like not textbook quality, but very representative images of the ones that so we taught them only to do the transesophageal 4-chamber, the transesophageal long axis, the transgastric short axis, and the bicable view. And so they didn't have to do every one of those views to get a good rating, but they had to do at least one of those, and it had to be what I would consider very recognizable imagery. You could see all the anatomy very well. And then fair was, you could see some of the anatomy. You could see the anatomy and you could see what you're looking at, but you wouldn't put it in a book or show it in a conference, because it's maybe a little bit oblique, but not a great image. And then poor was, we couldn't recognize really what they were looking at. The interesting thing is, even though there were a very high percentage of good and fair images, very few poor images. More common amongst the non-ultrasound faculty. It was very unlikely that ultrasound faculty would get only 1 case, it looks like, of poor images that you couldn't recognize. Now, this was only what they collected. We believe that the non-ultrasound faculty have less interest in looking at the images later. The ultrasound faculty get together once a week to do QA, so they wanted to show everybody how cool they were and how good their images were. So they were more likely to push the button and record images, whereas the other faculty, all in all, everybody reported that they could get a image that helped them in patient care 99% of the time. So even when they weren't collecting, they didn't do a good job collecting a video, they were still reporting that they could see the heart and make sense of what they're looking at and use it to manage the patient. Let's see. We actually looked at things like how long the probe was in place and when it was placed. And that on table 5, you can see it was put when the patient was actually in cardiac arrest, was a relatively small percentage compared to before and after arrest. So you can see those numbers here. ROSC before TE was placed, 35%. ROSC after TE was placed, 32%. And then when we say TE during CPR, that's the total, whether it just had to be placed in at some point while CPR was ongoing. And then the ones that we counted as just cardiac arrest were when the TE, the only thing we could record, that we recorded, the only videos recorded was with chest compressions ongoing, which was the minority. It was only like 30%. So most of these patients had TE images while before or after ROSC happened. So with a beating heart, not just, we thought it was a little less interesting when all they recorded was a bunch of CPR, but that was the minority of the patients. We didn't really go into we didn't really capture whether they thought it helped in the management. We were more interested in, is this feasible? Can this group of mostly non-ultrasound interested emergency physicians actually get TE images? Can they do it safely? And will they actually use TE? I was actually surprised at how much the non-ultrasound people use TE. 75% of the 557 TEs that were done during this period were done by non-ultrasound faculty. So they weren't afraid to put the probe in and use it. And let me see if there's, as far as safety goes, with 557 cases, we thought we could comment on the safety of TE in the ED. And there were 3 potential safety issues. There was one which the TE, the endotracheal tube was clearly dislodged while the TE was being placed. However, the person that intubated the patient was also the person putting the TE probe in, and it was just a few minutes after the intubation. So they just simply re-intubated the patient right away. There was another case where a patient came in from the field, intubated, and the operator who was placing the TE used a CMAC, a video laryngoscope, to place the TE, which was common, at least in the beginning of our series. And they noticed that when they looked in the mouth that the endotracheal tube was in the trachea, but the cuff was blown up above the cords. So they just simply pushed the tube down below the cords and then put the TE in. So I would consider that actually a save, which was not really related to TE, but it was a potential complication stopped by placement of the TE. And then there was a third crazy case where there was esophageal and tracheal disruption from a car accident where the patient had severe lower neck trauma. The patient was intubated, or they thought they were intubated. The tube went through the cords, and then when they tried to place the TE, it wouldn't go in. And then when they examined the neck closer, the trachea was gone, and it slid down into the chest. So the person was intubated, but the tube wasn't in the trachea. And they pulled the trachea up out of the chest and did a crike. And the TE, I don't think really had much to do with that. It was just that it wouldn't go in, and that tipped them off to the fact that there was something terribly wrong. So our conclusion was this is pretty darn safe. And even with people with, I think this is probably the minimal training you could do, is a couple hours of lecture and a couple hours on a high level simulator, and then go ahead and let them loose and let them use it. The one caveat is that we're a pretty high level ultrasound site, I would say. We have about 30 ultrasound machines, and we've always been a high user of ultrasound throughout our department. So I would say even our non-ultrasound people are probably pretty good at ultrasound. And I think the reason that they were able to adopt TE so quickly is they do a lot of TTE. And so as soon as they started placing the TE probe, they recognized the anatomy and had really no problem with interpreting the images. So I think this shows that if you're already good at TTE or fairly good at it, you use it regularly, it's not very hard to transition over to TEE. The one comment that we got from several of our, I would say, more senior people who aren't really known for their ultrasound skills is they love the TE because they didn't have to try very hard to get good images. All they had to do is put it down and they would get a good image right away. So I think that's kind of the high level review of or overview of the paper and what we did. And I'd be happy to answer any questions.
I'm blown away by the non-ultrasound faculty and how many they just jumped into the pool in the deep end, and this is incredible. You know, I always thought from like Felipe's studies, like you had to live across the street and drive, you know, ride your bike across the bridge, all that sort of stuff. Do you have cameras in that resuscitation room that can record each one of these cases in case some of the faculty did not record their views and that was like, you could still see the screen or anything like that?
We actually have cameras in the ceiling. Each case is recorded from above at 4 different angles. And that was actually used to verify some of the subjective data, like how long the probe was in place. But the actual images themselves couldn't be seen on those cameras. We actually are in the process of installing a system where all the ultrasounds that are done in those bays, plus the overhead videos, plus the vitals and other details of the case are all recorded in real time and then kept on so we will be able to do that pretty soon. We actually had that set up at one time, but it was kind of a homemade system and it had a lot of problems. So we have had that before, but it wasn't very consistent.
I have a question, less about the actual study, but more about credentialing. So we've been undergoing the credentialing through everything, and we did get a lot of pushback from cardiology. I really like what you said to them. That is amazing. But basically what we're doing is we are requiring prior to credentialing for the attendings to do 10 TEs on real patients, as opposed to like only high fidelity simulations. Did you run into that problem at all as far as actual credentialing?
Well, there is a recommendation by some societies that you practice on real patients, and I think the ACEP one actually says that, but it doesn't specify whether it's simulators or patients. It's much easier to do it on a simulator. I would say that I don't really love simulators, and a lot of simulators I don't think are realistic, but the TE simulator, at least the one we have, is very realistic, and I think you can immediately take the skill that you've learned on the simulator and go to a real patient. It looks very, almost exactly the same. After teaching these 52 people, some of them they didn't even really want to be there. And they picked this up very quickly. And, I had the same reaction. I was really shocked when we started getting the data back. And I'm like, why are these non-ultrasound people using it so much? And then I would ask them and they'd say, because it's easy. It's a lot easier than TTE. And so, I think that you could use this, basically our experience, to go to whoever's trying to make you do, view them on live patients and say that's not necessary. This big study shows that it's safe and effective and you get decent images, without practice on patients. So I would say that we looked at doing that, and to get 52 faculty, 10, TEs in the OR, it would have taken more than a decade probably to get everybody credentialed. And we did it in one day. So I think it's much better way to do it. I think that if somebody thinks that you need to practice on real patients, they need to come up with some data to support that, because I just don't think there is any.
That's great. Thank you. Yeah, we just went by the ACEP guidelines and we said 10 on live patients. So fortunately I had enough during my fellowship that I performed with cardiology, but the rest of our ultrasound faculty is actually going to have to go through cardiology and get their 10, and we're only doing it with ultrasound trained faculty. So that's really amazing that you got everyone trained.
Yeah, we have some amazing images that were done by people who aren't necessarily interested in ultrasound, and they found some just incredible stuff that, you know, we show in lectures, and it's encouraging that, like, you don't need a crazy amount of training on this. So, and I think we should go to cardiology all over the country and say, hey, you guys don't even run cardiac arrest. We do, and we're going to use it. We want to use it for this. And I mean, frankly, even their own journals that talk about the safety are all comprehensive TE exams where you're moving the tip of the probe pretty extensively. A lot of these were you just put the thing down and you don't even mess with the mechanical tip of the probe. So it's not even, I don't even think it's reasonable that you're going to damage the esophagus by just pushing this down and not using the mechanical tip. So I think the idea that it's somehow dangerous is crazy. The biggest problem that the cardiologist said that they were worried about when we were going to use it is that we would make someone aspirate. And I was like, you got to be kidding, right? like we're going to make someone aspirate who's already intubated, by the way, and then, you know, we intubated them. We're a lot more interested in aspiration generally than they are, but I was surprised that was the only thing they could come up with, and then they wanted to supervise us, which seemed kind of ridiculous.
Yeah, I'd like to see them come in at like 3 a.m. to come and supervise one of these things.
Yeah.
Are you able to see some of the comments, questions, or you want me to read them to you? What's best for you?
Maybe you should read them. I'm
Very good. So I got Jackie asked, what did you guys do for infection control? How many probes did you have initially during the study, and what CPT codes did you use for billing? There was a link to CPT coding put up by Jason Arthur. So mostly just the infection control and the how many probes.
I think we started off with 6 probes, and then we realized we would need more because we wanted everybody, every time someone wanted to use it, we wanted one available. And we used to only have 1 probe before we trained everyone. We realized with 1 probe, people they would hesitate to use it because they thought, well, maybe another cardiac arrest will come in 2 hours from now, and I don't want, you know, this patient can get by without it. But we really wanted everyone to use it at will. So we ended up getting a total of 12 probes eventually. But we do a pretty good job billing for our ultrasound. So that, you know, we have 30 regular machines, and that's because we have literally decades of really good billing practice. And so that allowed us the resources to get that many probes. I will
Can
say
I hire you to like come in my shop and like show us how to do it? Can I like pay you like a bunch of money to come and do that for us?
Me too.
I actually trained where you are.
Oh man.
Wow.
So yeah, I mean, I think you do need to have certainly more than 1, probably more than 2. Having a whole bunch helps. As far as the cleaning of the probes, we just did the same. We had central supply or whoever reprocessing, and just do the same thing as they do with the echo lab probe. So initially we weren't very involved in it, and then they kind of screwed up some of they would send the probes back and say this one's broken, and then we would say that doesn't look broken to me, it looks fine. And then we realized that they were used to reprocessing Philips probes for the echo lab, and they were confused because we were using Mindray probes. So we had to go down. It helps to go down there and see what they're doing and buy them. They just needed a piece of equipment from Mindray to help them test the probe when they were reprocessing it. So we did learn that we should watch how they, go down and watch how they're reprocessing it, and make sure they're doing it right, and be an active part of it. And, we have broken some probes, certainly, but they weren't broken while we were using them. I think they're broken in the handling process, going back and forth to downstairs to get cleaned. The most common problem we've had with the probes is the electronic steering mechanism somehow goes haywire. But they still work. They just can't be electronically steered anymore. They're kind of stuck at 0. We've had a few tears in the insulating covers of the probes, and I don't know how that happened. That wasn't during use, I'm pretty sure. The one interesting thing in this that we put in the paper is that there was a question of, there's always been a question of whether it's okay to defibrillate with the probe in place and whether it's going to hurt the probe. We did it 104 times in these 500 patients, and it didn't seem to affect the use of how the probe worked afterwards. So I don't, it's possible that's hurting the probe, but nothing we could detect. It worked just fine after the shock. And I actually go out of my way to hang onto the probe during my cases to, see if I can feel anything. And I've never felt the shock come through or anything. So, so you won't get shocked and fall down if you're hanging onto the probe. You don't need to let go of it and run away during a defibrillation.
And we have a couple of more follow-up questions real quick. This was sent to your standardized processing unit. This was not a Trophon device or something in the department, correct?
No.
Okay. And then Felipe had a couple of questions saying, amazing work. Looking forward to the team's next 500 scans. Good luck. Was the QA
I think they're already
data
done.
form, was the QA data form designed and established a priority when the program began, or was it made for the analysis phase afterward? And then if so, did it include the endpoints of like study success, early complications, findings, etc.? And then he also mentioned later on standardized data collection to define and track complications throughout the literature. And then if you'd be willing to share your data instrument, I'll connect you guys via email. That way that can happen.
Well, so we didn't do a great job. We set up a database, which we thought was pretty comprehensive to collect all complications. And we tried to anticipate anything that was going to happen, whether it was interesting cases, difficulty placing the probe, that sort of thing. And we thought we had a pretty robust database. But as we went along, we realized that we wanted to add categories. And so we ended up going back. It was actually good that we had the cameras in the ceiling, because we're able to go back to cases where we didn't collect certain data points and collect some of that data in retrospect. But we now have we collect more data on each case. And it'll be nice, like you said, when we get this video system up and running, where we see live video of the patient, the thing being placed, and the actual ultrasound, continuous ultrasound video of the entire case. And so that should be that should get connected in the next few months.
Wow. Very impressive. Very impressive. There's also questions about cleaning with a Trophon or a T-clean. I would encourage anybody who's doing this to check with their OR, check with their standard, their sterile processing unit, because we tried to do this with a Cydex system and no way. But then our OR, turns out they have a really fancy machine, because many of our anesthesiologists do TEE, and have actually been good allies for us. And so they just clean our probe now.
Yeah, I would just go with a system that's already set up rather than trying to make something new.
Because the tracking requirements are really high for the TEE probes, as matching the patients and all of that stuff. So it's great to go with your system. And Maya asked about sharing the name of the new video recording system you're using.
It's actually I think it's a beta system that the company's never done before, but it's I can't remember the name of it. I can get back to you on that. It's the company that used to be part of Taser, and I think they broke away now, and they specialize in they make like video cameras for law enforcement that they wear, and so it's all very secure. And I think they're trying to get into a new line of business here. But if it works, I think they'll sell this to a lot of hospitals, because it's awesome to have video that can, because a lot of the things we do on critically ill patients now are videos, like the intubations, certainly the ultrasound, the monitors, everything that's video or image has an image capture should be like kept as part of the chart, I think. So I think they're trying to get into that. So that I don't think they've ever done it before in a hospital system.
Interesting. So there are some other questions in the chat, but they have to do with cleaning, and that sounds like we could almost have a small group discussion on that with the ultrasound community. So we'll explore that option about doing that and see if we can come up with some solutions. I just had one other question about, so if you look at how many people were using TEE during the study compared to how many are now, is everyone still using it, or has it dropped off?
No, I think it might have even accelerated. I don't remember the number that we have now, but we stopped collecting for this data sometime in 2000, and we actually had like 50 more at the time that we collected this data. We just had to stop somewhere because it became so cumbersome to put all the data points together. Yeah, but there's well over 1,000 now. It might be 1,200, but there's a lot. There's so many that it's hard to keep track of.
Mm-hmm.
And we have to go back, and we actually had one of the research fellows take over the database, because I was doing it for a while, but it was just really hard for me to keep up with putting all the patients in there by hand. So now we have fellows involved, and it's easier for me, but I don't know the exact number right now, but it's a lot. So
what's your next paper going to be?
I don't know.
All right.
I wanted to do this one just so to get it out there, because I think it helps other departments around the country argue that there's not a downside to doing this. There's not a safety problem. It's credentialing and training should be fairly easy. And so, yeah, I think everything else can get worked out. I think there's enough data on TEE going back to the 90s from ORs and critical care that this is really helpful when someone's really sick, and especially when they're near cardiac arrest or in cardiac arrest. So my feeling was we didn't need to reprove that. We just need to prove that we can do it, and how to get everyone trained and using it. And then I think there'll be a lot of papers coming out. I think I'll let the research fellows work on the next one, though.
All right. Well, thank you very much for joining us. I'm getting poked by Dan that we need to move on to the small groups, but I think this was actually worth extending our time a little bit. So if you want to stay for the small group sessions, that would be great. We're going to be discussing the second paper from resuscitation. It's point of care ultrasound and out of hospital and ED cardiac arrest. So it's not a TE paper, but if you want to hang out, that would be great. Otherwise, Dan, I'm going to go ahead and just let you put us.
I have to go through security, and then I'll jump back on.
But we may be done by then. But
I'm just going to open up the floor to the moderators for major discussion points or key things that came out in your discussions.
I think one of the questions we were wondering was why exclude after like 5 minutes or before 5 minutes of the resuscitation ended. And I realized that was like maybe to counteract some of the bias, but if anybody has a more eloquent answer that I could give my group, that would be helpful.
yeah, I mean, they say it was to counter the bias, and probably also to counter the people who had the short resuscitations. I mean, you either called it immediately or they resuscitated immediately. So you never got the probe on them, or you may have just looked one time. And so they decided that it would be cleaner to exclude those. I don't know. And I'm going to let Felipe talk for our group because he does research on cardiac arrest and ultrasound. So I'm going to let you kind of summarize the couple of the points that you made. Unmute. Unmute.
There we go. Thank you. Sorry about that, Sandy. So for those of you that are fellows here, I think the first thing to say is that this study by Romulo and their network was nothing short of monumental, and it was like a really great example of the power of coming together and collaborating, first of all. The second thing is that there's definitely a lot of value, and we learned things from this study, but this study had a lot of limitations, and we as a community should learn from those limitations. And one of those limitations is, I think it was already mentioned, the patients that were excluded. I think the explanation for why they were excluded beyond under 5 minutes is because it was simply not feasible to grab those patients to incorporate them. So they define the inclusion criteria as after that. As we discussed in our group, there are a lot of difficulties in cardiac arrest research, and specifically in echocardiography in cardiac arrest. But one of those is timing, and the timing of interventions is actually key, and it's really problematic, and it really makes it very difficult to interpret the efficacy or the impact of the intervention. In cardiac arrest, we know that the longer you have a cardiac arrest for, like the longer that you're down, the longer that you're getting CPR, and the longer overall that you're being resuscitated, the less likely that you'll survive and the less likely you'll have a good outcome. The opposite, the shorter of all those times, the better outcomes that you have. And so when we deploy the intervention, it's actually super important. And this is one of the greatest limitations of this study, in that there was great variability, and to some extent, we didn't actually know when the patients got their ultrasounds. So all we know is that the ultrasound showed positive activity or negative activity, or lack or presence, but we don't know exactly at which point that was being evaluated. And that is probably the single most problematic sort of point of the data. And as we go forward, as we think about how do we design better study, this is what I kind of try to hint at with the question for Rob. It is really important that as we design studies that we define upfront what is the data that we want to gather, even if it's going to be an observational study. We need to design that instrument and make sure that we are measuring all the variables that we need. So that's I think that the version 2.0 of the study of the reason is certainly including a lot more of this data of those other unmeasured confounders and covariates. And the same with TE for the studies that are happening.
Okay, thank you. Yeah, we need to wrap it up, but we'll go over for a few minutes. So everybody who can hang on, please hang on. Other groups?
I was in Petra's group, and our main point that we found in the article is that I noticed that they talked a little bit about like the pericardial effusions. Well, I think one of them got a drain, and then the pulmonary embolisms as well, but that it didn't just specify whether or not they got thrombolytics. And I don't know, kind of feel like those populations should have had their own subgroup analysis, because that's a potentially reversible cause of ischemia that is separate from the typical like electromechanical dissociation that's often physiological. It's almost purely anatomical problem, and that's probably should have had their own analysis on, especially if they had an intervention separately from the rest of the group.
Yeah, that's a good point. You almost wonder if they should have been excluded because they had a different mechanism causing their arrest. But yeah, good thought. Anybody else?
I mean, I guess the other thing that we had kind of brought up too was like the outcomes. Like, it would be nice to know the neurologic status of people at each of the time points at discharge. I mean, not that I would necessarily predict ultrasound to know people who get good neurologic outcome, but it'll be interesting to find that out. We don't know if we don't look for it. So. No,
and that's actually one of the data points that for this international guideline on cardiac arrest studies. That's that is the final endpoint that they really stress that you should capture. So we know what we're discharging from the hospital. So that's all right. Anything else real quick? I think we're done. So next month is going to be biliary and GI. And as you can see, there's a message from Petra Duran-Gehring, who says, I got to run to shift, but I'm doing next month, and she is. So please, if you have an interest in moderating, we make it really easy. We give you this handy dandy guide, and it's really fun. It looks good on your CV. So if you're ultrasound faculty, you don't have to be a fellowship director, please email Petra, or you can email me, or if you email any one of us, we will find you and put you on our moderator list. And I think